It's okay. I mean, when you walk out of here and they give you that degree, you've got a base. In the years to come, you'll get a base knowledge that will expand. But don't feel like you have to do everything all at once. You still learn, okay? Not a big deal. Just keep it up, keep reading, keep doing what you're doing. All right, so the occult pneumothorax, stable patient observed regardless of positive pressure ventilations. I'm not so sure that, you know, CPAPing the patient with a pneumothorax are some of the things, you know, you get into tricky situations with this one, okay? I usually just say, you know, call the pulmonologist with this crap. But, you know, obviously if you got somebody under pressure that's got a pneumo, can go quickly to attention. Okay? Just got to know that. And when they're ventilated, that's another thing. Okay? Sometimes it can be very helpful, sometimes not. So I'm not too up on as far as what kind of these guidelines they want to do and stuff, but I bow down to the specialist on these. But if you think or you're looking and you got trauma, CAT scan the patient. It's okay if they get CAT scan. Okay? You know, if you think a chest x-ray or if you're missing something, just get a chest x-ray. Oh, I don't know. Oh, hell, CAT scan. Really? Yeah. They come back and then you look like a genius because you found something. But don't ever just sit there and it's like, I don't know, should I help just a CAT scan. It's easier said than done. And guess what? You're not second guessing yourself afterwards. Tension pneumothorax, yes. So, this is the one where air keeps going out. Basically, you breathe in, air goes in, goes through the lung, and just starts to build up in the chest. Every inspiration gets tighter and tighter and tighter and tighter and tighter until it just compresses everything. Compresses the heart vessels, compresses the heart itself, compresses the lungs, and it kills you quickly. Only way to relieve that is get that air out of there. And if you've ever seen a needle decompression with a new tension pneumo, it is impressive. You want to talk about whistling air coming out of the chest? It is immediately responsible. You usually go into mid-clavicular line, second intercostal space, and I've had to take a 16-gauge needle and put it in there. I've not had, they got new little coiled needle aspirations and things that they do nowadays, but I don't care what it takes. Just get it in there and get it out, because if you don't, the patient's dead. And that's the only way to do it. You don't have the time to prep and do everything, get a thoracotomy tray out and open that patient up with a chest tube. Needle decompress them, stabilize them, then put a chest tube in. Okay? Yeah, I mean, diagnosis really, yeah, it is clinical. They're going into respiratory distress, start to show signs of shock, you know, blood pressure's going down, breath sounds, you know, going down. Distended neck veins can happen. Hypersomnolence, you know, if you're sitting there and you're cussing on them and you're hearing all that kind of stuff. I mean, I don't know the last time I was sitting there tapping on a guy's chest when he's croaking on me. I mean, technically, yes, that's something you can do, but, you know, that's the last thing I'm thinking about is my butt cheeks clumped on one another. Obviously, it does require emergent decompression, all right? Needle to decompress them, then you have to put a chest tube in them to stabilize it, okay? I'm talking about chest tubes and all that. Hey, anybody ever seen chest tubes set up? A couple of you? Okay. This is, so, I've seen it.
You get this Thursday.
Oh, you? Well, I don't have to talk about that. There is a certain way you need to put a chest tube to suction and water seal. Okay, that is very important. I'm just going to tell you, when I was at Tulsa again, I've seen a nurse take a chest tube and put it right to wall suction. I thought a thoracic surgeon was going to have a stroke. Not the appropriate way to do things. Okay? There's a reason it's the water seal. Okay? So, but you'll get that lecture later. I don't have to do it. Again, mid-cubitular line, second intercostal space is just kind of showing you. That's this place right here. I'm Mr. Happy. This is kind of the, yeah, these are old. I don't know what that is. It's not some of the newer ones, but obviously this guy's been in some type of trauma, it looks like. Yeah. So, yeah. You don't need a syringe on there to suck anything out, I guarantee you that. Again, you can see pressure all in this. You see everything, you see where the heart is, see where the great vessels are. It can be significant. If they're getting a chest x-ray at this stage, you kind of wonder. That's impressive. Oops. Yeah, chest tube afterwards. Showing it, lungs all the way out. Placement of chest tube. If you have a pneumothoraces and you're putting one in, you know, again, they're going to tell you where it's going to be mid-axillary line. You're going to be in the triad of the latissimus dorsi. You're going to be in the mid-axillary line, about 5th intercostal space. Pneumothoraces, 2, superior, okay, go north to the apex. Hemothoraces, go to the base, okay, typically. I mean, that's usually the general placement of the chest tube. Right? Blood's not going to fly to the apex. Air does go to the apex. That could, I mean, that should be kind of intuitive, but not always. Open pneumothoraces, sucking chest wounds. Always need a thoracotomy. Okay? You need to put a tube in there, and you're going to put wet to dry dressings on these things and close them up. Okay? Let them heal up. These are impressive wounds. Looks like kind of a stab wound and stuff done, or some type of penetrating trauma. We've got done to this patient, but always put a tube in these. Again, smaller pneumothoraces that are stable, pulmonary PT, pulmonary spirometry, all that kind of stuff. Repeat films, don't let them go home.
This may be a stupid question, but when you, so if you're like trying to go into a patient's chest to fix a tension pneumo, and the lung like inflates pretty quickly, yes?
You can, yes. But a tension pneumo, I mean, the air coming through those needles, I mean, it's just not going to go.
Right.
Yeah, right. I mean, it's slowly going to come up into that, yes.
Okay, because then, so as the lung inflates, do you just put in like a tube or something so it doesn't
Well,
inflate?
you put,
into
when
the
you
needle?
go into needle decompression, you put the tube in, right? You pull your needle out, your trocar comes out, and then the tube stays in.
Okay, I wasn't sure how fast it went. It's going to
Yeah,
inflate, and you're going to pump
no,
the lung. and it's gonna
You
be
can
good.
lacerate the lung. That can happen. Has anybody seen the trocars of a chest tube anyways? Has anybody seen a chest tube placement? Are they going to go over chest tube placements?
Thursday.
Okay, that's it. Never mind that. Kelly's is the best way in my impression. You see the trocars. Yeah, Jesus Christ. You think you're going to drive that thing right through a heart? You question it. Chest tube required, you know, typical suction, transition to water seal, that's the main thing. It needs to be the water seal, okay? You need to keep sterility of the pleural space, which that does. Plus, if you see bubbles in the water, still not need to keep the tube. No bubbles, patient good. Bubbles, bad. Got to take the chest tube out once it's resolved. This is persistent air leak over 3 days. That usually is going to prompt a VATS evaluation. Okay, so it's a little bit more involved. Anybody know what a VATS is? Maybe I'm speaking out of turn here. Video assisted thoracotomy exploration. Laparoscopically going in and take a look and see what the hell's going on. Do they need to fix the lung? Why is it not? Usually the pleural space or parenchyma of the lung heals itself well, that you don't have to do too much, but sometimes you got to go in there and find out. VATS are just very good because it's not really doing full thoracotomy and going in and looking, and you just go in, you know, video guidance and seeing what's going on. Oh yes, they all ask the question, when can I fly again? Flying is always in a, believe it or not, when you're in the airplane, you don't do it, or you don't notice it because they do it very slowly over time, but you're pressurized, right? They got a lot of pressure in there to keep things going. So usually 2 weeks, and get back to flying. Hemathoraces, blood in pleural space. So massive hemothorax greater than 1.5 liters. If you put a tube in somebody and they damn near give you 2 liters of blood out, there's a major problem. Okay? They're going for surgery. You can get tension out of these, but you're giving them fluids. You know what a cordis is? So basically, you take the femoral artery and you take the big bore IV and put it in there for central line, and you get these rapid infusers that can take about 4 liters of blood and slam it into somebody in about 30 seconds. So you'll get these cortices in there, you get these rapid transfusions going and stuff of that nature. But this patient, more than likely, is going to be that small amount of percentage that's going to go for surgery. They're probably going to get a thoracotomy. All of them, if you've got blood in the pleural space, need to be drank. It is imperative of this fact, okay? Blood in the pleural space is not a good thing. It causes pressure upon the lungs when you get pneumonia, but the worst thing about it is these damn things turn into empyemas quicker than devils, and people get sick as a dog. I've seen tension pneumo. Hell, I've put in a chest tube in a tension pneumo empyema in a drug abuser with staph. 26 years old, on a vent in ICU. It's not pretty, and damn it is stank. But these people get sick and sick quick. You've got to get the blood out of the chest cavity. You just cannot let it sit there. The other thing about it is that blood has all the components that we have in our body, so then they start getting scarring, or they get lodulations and so forth. And it just causes just a massive amount of crap in the pleural space. You've got to get the blood out. The other thing about it is when someone has a hemathoraces, you're going to put a tube in there because you're going to measure output, right? If they continue to put output of blood, that's not a good thing. Okay? If they're still giving out around 200 mils an hour for several hours, you've got to go in there and surgically say, what the hell's going on here? Did they nick an artery? Did they nick one of the veins? One of the drink vessels done? Is what's going on? So you're going to have to go explore it. You know, is the ventricle compromised? Things of that nature. Massive hemothoraces can cause tension pneumos. They're not as impressive as air tensions because of fluid dynamics and things. Neck vein is really not a good indicator because it doesn't really compress too much. Okay? Not like what the air pneumothoraces will do. Again, rapid restoration of volume. Again, blood, rapid transfusion of blood, libo negative unless you get. The other thing about it is that you can get these cell savers and stuff, and anything coming out of the chest tube, you can recycle back to the patient. It's okay to use the patient's own blood. Chest tube for adequate drainage, again, occasionally requires operative intervention. Someone got shot. This actually brings in an important point. Is this thoracic or abdomen? Yeah, I don't know. I mean, that could be, that diaphragm could be up here. Don't know, because we got a pacification, there's a whole lot of blood in there. But that could be intra-abdominal. Now, you gotta understand, the liver's sitting over here, here's the spleen, right? Indications of the good old thoracotomy. Everybody's life and death, ER, crack of the chest. Everybody wants to crack a chest, right? Put the rib spreaders in, get the cardiac lavage going on. Surgical intervention rather than absolute numbers of initial or persistent output. So, you know, again, 1,500 mLs, that's significant blood loss in a patient from the chest, okay? You've got to have, you know, prompt ability to say this patient's got to go. You've got to get in there and figure it out. That amount of blood in the chest is not a good thing, okay? Patients still with 200 mLs an hour for several hours, probably going to go for a thoracotomy, okay? That's probably not going to be as emergent as maybe the one that comes out at 1,500 right then and there, okay? And I mean, this can get gory. I mean, I've seen ER rooms where, you know, it's taking up buckets and mops to clean the floor. It's impressive. It can be very impressive. Retaining hemothoraces, again, you know, you get the risk of empyema, you get pneumonia, fibrothorax. I mean, you get these lodulated type problems and stuff, can cause aerodynamic things of the lungs, atelectasis, you know, just a lot of things. You have to clear the blood out. You just can't let it stand in there. High rates of empyema and pneumonia, VATS has high success rates by timing is not known. So, you know, when should you go in there and video assist it and look at it? I don't know. But again, you're gonna have a higher rate of thoracotomy with this just because life-threatening things occur. Is it the great vessels? Is it the lungs? Is it the heart? What is it? So they're really, you're gonna crack a chest as quick as all get out. Again, retaining hemothoraces, again, you're not just going to put another tube in, you're just going to go like VATS. It's one of the best ways to do it. It decreases risk of infection and conversion to thoracotomy. Thrombolytic sometimes is put in there just to improve drainage. The subacute ones, just because of the coagulation of it, busts up the stickiness of the clots and stuff and allows it to drain. So sometimes that's used. Again, that's nothing that y'all probably going to be remanded to. Penetrating chest tubes as the box. So the box basically is the most important vessels of the thoracic cavity. Obviously the heart, great vessels. Once they've been busted, you know, that's a major issue. That's not a good sign, right? Thoracoabdominal trauma. Anybody done a FAST exam? Anybody seen a FAST exam? Anybody know what a FAST exam is?
A quick exam.
So, and I got a skills lab I gotta go to and stuff. Here before long for St. Anthony. So FAST exam, basically, you get somebody comes in, I'll give you an example. So, I was working 3-4 months ago. Dr. Sloan and I are covering the East Plex of St. Anthony's out on I-40 in Douglas. Okay? In a matter of 3 hours, he gets a tubo-ovarian abscess that ruptures. He's give her blood and she's going to surgery. I get a ruptured ectopic tubal pregnancy that I have no blood to give because we only have 2 units of O-neg, and just give her fluids and try and get her to the main hospital. And then a mother walks in with a 6-year-old with a GSW to the abdomen, self-inflicted with a 9 mil. Fun times. So basically, entry wound was here, exit wound was here, right through, okay? So in that, when you do a fast exam, basically you get the ultrasound machine, get in there, you just lube the patient up, and it's just a quick looking thing. You're looking for fluid and fluid only, okay? And you do it in several spots. You do the ultrasound right at the heart area, see if they've got a cardiac tamponade fusion. You look down at the bladder to see if they've got any blood around the bladder as far as any intra-abdominal type things. And then you look at the kidneys or in the flanks to see if you see any fluids. And it's just going to be just black appearing on your ultrasound. So a fast exam really tells you the extent of what you've got going on. It's quicker than getting a CAT scan, quicker than getting a chest x-ray. Chest x-rays don't always tell you anything. And sometimes you don't have time to get the CAT scan and tell you exactly what you're doing. Laparotomies, you can do cutting somebody open, washing it in, trying to pull blood off of it. Their negative rates pretty high. Complication rates can kind of come with it with peritonitis and everything else, but laparotomies aren't always the best indication. Diaphragmatic injury, that could be bad. You miss something, goes on with it, you get abdominal viscera that go up through injury of the diaphragm, strangulates, high mortality with it. So, but these are just the tests that you're going to go through, doing Doppler, doing ultrasounds, doing all these things to kind of look to see what might be injured, what might not be injured. Laparoscopy, therapeutic laparoscopy is looking for things in it. Sometimes you can see that in some of these patients, diaphragms are injured. In these studies, I didn't even look this one up to see, surgical laparotomy versus endoscopy. The laparoscopy is going to be the most invasive that you can do, but tends to be a little bit more efficient in doing things endoscopically. You just really need to open them up and look. I mean, it's basically what I'm gathering from these people. But negative laparotomy is significant in about 30% of these people. I never did understand what this was either. I think that is a heart. Yeah, I think it's a heart that you can see. It's into the right ventricle.
Be able to see that with a transesophageal echo? No? That's not in that picture.
Yeah, it's not far enough down. Scans, you can see penetration wounds. They're here down in the abdomen and stuff, what they're going through. This is where the injury is occurring, what it's involving, this in the kidneys and so forth. They contrasted this, as you can see, with contrast in the kidneys. That's a hell of a looking entity, isn't it? But again, this is a diaphragmatic injury that's looped up, so this is bowel and everything that's all up in there. ED thoracotomy. I don't know. Sometimes it just depends on what it is. I mean, is the patient live? Is it truly life-saving? Is it something that's going to go on? Is there a sign of life versus just vital signs? Are you really going to crack somebody open because it's the right thing to do, or, you know, is it just time to halt things that need to go on? Do they have respiratory motor effort? You know, are they actually doing some things? Do they have cardiac electricity, pupillary active? You know, pupils aren't really reactive. Brain depth is pretty high. You know, resuscitations really aren't going to do anything for this patient. Timing of the arrest, presentation in the ER, you know, if they're out in the field, they've been, you know, pumping this guy's chest for the last 45 minutes before they get to you, odds are that, you know, there's really nothing you're going to do with this patient. You know, if they arrest 2 minutes before they get there and they pump the chest, you know, odds are cracking their chest could be life-saving. Okay? Was it blunt trauma versus penetrating? So the indications, less than 15 minutes, you know, pre-hospital CPR that's witnessed. Penetrating non-thoracic trauma, less than 5 minutes pre-hospital. You know, patient staying witness blunt trauma with less than 5 minutes pre-hospital CPR. Persistent severe post-injury hypotension. You know, is it cardiac tamponade? Is it hemorrhage? Is it an air emboli? Some of these things can be very hard to discern. You know, an echo can show cardiac tamponade, obviously, hemorrhagic necessities, you know, chest x-rays and so forth might be able to show it. But if it is persistent, less than 60, you're pumping this guy full of fluids or female full of fluids, nothing's doing, this is when you're probably going to do. This patient's still alive in your ER. And if you don't do anything, they are going to die. That's an indication to actually crack somebody open. I've seen somebody get cracked on one side, get cracked on the other, and then open up the belly, just leg that patient wide open. The reasons that you're going to do it, again, when we talk about, you're going to cut a hole in the pericardium, right? So you can get rid of the tamponade of the heart. You can control cardiac hemorrhage. You know, you can throw a figure 8 stitch into something that's been stabbed into the ventricle. Control intrathoracic bleeding, evacuate massive air emboli, perform open cardiac massage. It's an interesting thing. Auricular occlude the descending thoracic aorta. Sometimes that's what you have to do. Clamp it. It's not the greatest thing to do. I mean, I wouldn't want that done to me, but it possibly saved my life. It's something that you do to keep from bleeding out. Again, this is the lung that's coming out in the thoracotomy. This is the chest spreader as they've gone in. It looks like he's had some type of penetrating wound that's gone in and probably clipped his heart. You can see a figure of 8 stitch of the ventricle. Another ventricle, I'm not sure what the hell he did there. Questions? Nothing? Anything? Nothing?
Comment?
Still have an hour before I can go off, so.
Yeah.
Take some.
He does play golf.
Do what?
You want to play golf on Saturday?
Where y'all go?
Golf club at Batman at 8 a.m.
I gotta work 24, unfortunately.
Oh.
Or I would have. What is it for your class?
Yeah, it's sponsoring or benefiting Good Shepherd Ministries.
Good Shepherd Ministry.